We are live now. Ranvijay, your host. Dr. Kocher, we are live now.
Right. So, good morning to all of you. A very warm good morning from NABH. And my name is Dr. Atul Mohan Kochar. I am the CEO of NABH. And NABH is very, very proud today to bring to you some master trainers who are masters in their field, masters in their art. And this is a very, very important webinar for all of us. The next in the series of our Quality Connect initiative, learning with NABH to all of you. And this very important theme today, basic life support and revisiting Code Blue, visiting these skills together. So this is a fantastic opportunity for all of us to learn from four master trainers who with a passion and zeal are going about the country to spread awareness about this very, very critical and important part of saving a human life. Without much ado, I know that thousands of people have registered for this training. Thousands of people are keen to learn from them. So I'll not come in between, and I'll surely just like to introduce these people. So just give me a minute, sir, so that I can share the screen. We have with us Dr. Shakti Dutt Sharma. He's not only, all of them rather, are not only astute administrators looking after key hospitals, key departments, but they are very, very passionate critical care specialists. Currently, Dr. Shakti Dutt Sharma is at Baba Saheb Ambedkar Medical College and Hospital at Rohini, but he has spent a lifetime at Lok Nayak Hospital. He's a state award winner for Best Doctor of the Year 2013-14. He has a huge number of publications. He is the principal assessor with NABH. He's part of so many committees, and he's conducted workshops, CMEs, more than 500 in number. His area of special interest is exploring new ways of interaction, teaching, training, resuscitation, life support, airway management, so on and so forth. This just one slide will not do justice to you, sir, but welcome, please, here.
Thank
We
you.
have with us Dr. Rakesh Kumar. He needs no introduction. He's a director professor of anesthesiology at MAMC, Maulana Azad Medical College. More than 50 publications, more than 2 books authored, editor of 4 books. He has more than 30 chapters, more than 500 workshops. So what can I say, sir? He has had all the major positions from president, training center coordinator, MAMC, and training center of MAMC is a very reputed place where there's nobody in the anesthesia fraternity who does not need to know Dr. Rakesh Kumar or all of the others. So he has won so many laurels: WHO Fellowship, Award of Honor of Meritorious Service, International Faculty at World Airway Management, and his area of special interest are also same, along with diabetes. I see that there, sir. Dr.
Thank you
Sunil
very
Kumar,
much.
sir. Dr. Sunil Kumar, sir, he's the additional MS, Lok Nayak Hospital. He's held all major positions, hands-on. We have all learned from him, and he's a very, very passionate teacher. And his area of special interest include learning, teaching, resuscitation, uh, uh, all those things, sir. He's been associate editor of Basic Life Support, an atlas-based approach. And this is one book we have all learned from. The second edition is now there. And he's also contributed hands-on in more than 500 workshops. So welcome, sir, Dr. Sunil, sir.
Thank you,
Welcome.
sir.
We are grateful to have you. And Dr. Anil Misra, sir, MBBS, MD, DA, Head of Department of Anesthesia, his current position. He's a very, very suave, dapper, and a very sophisticated man. But his core area of interest include learning, teaching, resuscitation, life support. So practically all four are hand in glove in their passion and to take this mission of creating awareness about basic life support to every person. So what I've learned from them, if I can say in one word, is that they all want that the last link, the guard at the door, the help in the office, they all should be made aware about basic life support. And one part, when we look from NABH angle, is that code blue. I mean, we are used to observing code blue teams, all are used to observing all these things. So this is their passion. So Dr. Misra is also the associate editor. He is a keen dramatization man, and we have seen him in action and so many real workshops. He is trained NABH staff also, and he belongs to the proud family of AFMC, and sir is very, very well known. And all of them have contributed to more than 500. I mean, there is no corner of country which is there. So we are very proud to welcome all of you, sirs, for this workshop.
Thank you very much for that very kind introduction, Dr. Atul.
Please, sir, please. Thank you so much. And just a minute. I'll just stop the share. And all of you, welcome once again. And are really hopeful that all those audience which are there, and we'll be putting this webinar, this training on our website also. So all of you can keep on revisiting and learning and improving your skills from this thing. So I'll hand over to Dr. Rakesh, sir.
Yeah, he'll share the screen.
I'll share the screen, and Dr. Shakti will be with you to begin with. I've shared the screen. Yes. Sure. Yeah. Okay. And this being already done, there we are.
So thank you, Dr. Atul, for inviting all of us to this webinar. And we welcome all the participants who will be looking into the skills with us. What is inside the code blue? So we will be visiting the skills together. Some of the skills we will be doing together, and let's begin with the code blue. How do we define code blue is that suddenly a person, it's an emergency situation, and it may be announced in a hospital or institution in which a patient is assumed to be in a cardiopulmonary arrest. Now, this announcement, once it is made, either verbally or on telephonically or with a press of a button, this announcement prompts a team of healthcare providers, which we usually call as a code team, to reach the specific location and begin the immediate resuscitation. Now, the care providers at that point of time, once they have reached the area of resuscitation, now their decisions are very much important, and the decisions which they take within 15 to 30 minutes make the difference in the outcome of resuscitative efforts. Now, these actions which they take are based on updated guidelines and best practices. So, life and death situation, if you make correct decisions, the patient might live. If you make some wrong decisions, the patient might not live. No? So, why we should know about code blue? Because it is our job profile. Whenever we are working in the hospital, either we are looking through the eyes of the assessor, or we are in the team which is providing these resuscitative efforts to the patient. Now, the assessor has to decide how the first responder has reacted to the simulated code blue situation. This is a training in which if we keep on simulating the things, we will try to improve ourselves. And the code blue situations, if we come across in a simulated manner frequently, the actual patients will be saved. Now, why we have been chosen by Dr. Atul Kochar is that we have ensured that all over the world there is a standardized approach. The language of resuscitation all over the world is same, and all the lifesaver providers are on the same page. We have trained about 50,000 healthcare providers in last 15 years, and we have a book which is Basic Life Support and Atlas-based approach, and all of us have contributed to this book. This book, the Basic Life Support and Atlas-based approach, is available in the market as well as Amazon and Flipkart. So anyone can have this book from us or from the e-solutions. Now, we need to revisit these guidelines. The guidelines, do we remember the updated guidelines and critical steps required during the code blue? That is, we have to revisit. Now, so today we will be looking into the updated guidelines and critical steps, which we will go through in the code blue situation. Now, we will refresh the critical points in the checklist. As Dr. Sunil used to say, the skills are perishable. So we keep on revising our skills. And once these skills are there, they will not be perishable. So frequently, we will be revisiting these skills in a simulated manner so that once the actual scenario happens, the patients are saved, the lives are saved. Now, we have to see, does the cardiac arrest occurs only in the admitted patients? It can occur outside the hospital. It can occur within the hospital. The patients are not admitted. Certain situations are there, which we will show you.
Yeah, when we were discussing and planning for this presentation for the NABH, I asked Dr. Rakesh and Dr. Shakti, the cardiac arrest can occur in the premises of the hospital, may not be in the admitted hospital. A person can be absolutely normal. And with this idea, we want to share a few videos with you. I think most of you have seen. So this is one video where there's a conference room and a meeting is going on. This is the Punjab National Bank manager, and it was a retirement day. So audio is not coming.
I can hear it.
Yeah, okay. So okay.
Coming very well, sir.
Thank you. So this was the GM who was giving very passionate and very emotional speech on the last day of his retirement, last day of his service, and suddenly he collapsed. Right? Why I'm sharing these videos with you, I'll come a little later. Sir, can we see the next video? So here the party is going on.
This was in the hostel, I think, isn't it?
Yeah, hostel, yeah. One of the resident marriage. Now, you must have noticed here everything was normal. He was dancing, enjoying, and suddenly he felt something, and he was unconscious. Right? Why he went unconscious? Again, we'll discuss in detail a little later. Can we see, sir, the third video? This is the hospital scenario. A resident doctor was on duty. You must have seen all these videos on your social media, right? So why I've shared these videos with you, in all the three videos, all the three scenarios, the person was absolutely normal a few minutes back, a few seconds back, right? And you're seeing all during at the age of 60 years at the young patient and again around 50 to 60. They were absolutely normal doing their duty and suddenly they collapsed, right? Now, how we are going to manage a little later. Dr. Shakti, can we start?
Yeah, so good morning, everyone. Thanks once again, Dr. Kocher, for being with us and having that much faith in us. I'm sure that we are all going to learn at the end of the session today, and we'll be able to sort out most of the questions which are there in the mind of the people who are attending this. So we'll try to see what is what exactly is code blue. Before going into that, we must have in our mind very clearly the philosophy of resuscitation is that when a person is about to collapse, like Dr. Sunil showed in two videos, first two videos, you saw that the person before collapsing, you know, the person who was giving the speech suddenly became quiet and people looked and suddenly he collapsed. The person who was dancing again got some time, but nobody understood what is coming. And so for healthcare providers, for the last 10, 15 years, the international guidelines say that if you could prevent cardiac arrest from happening, that will be great, right? Uh, but if the arrest occurs, which we are talking about today, which is the code blue, how do we treat effectively? How do we react? How do we perform in those initial few minutes, as Dr. Shakti told you? That is what. How do we treat effectively the person who is collapsed? That is what code blue is all about. So the first philosophy is try to prevent person from getting into an arrest situation. But if he or she does, then treat effectively by using the latest guidelines and whatever is there in the literature and the best of skills. And another thing which is less commonly dealt with is support humanely with the people who come with the patients. That of course is not part of the talk today. So what we are doing today is the treating effectively. How do we treat effectively? But it is important that we do take care that the person who come with the patient, their relatives or attendants are also in the loop and they are not left out and they get a huge sudden shock that the patient who had come in talking and has suddenly collapsed. So it is a very small humble request that they should also be kept in the loop when we are performing the code blue. One of us can spend a few seconds with the patient's relatives and attendants so that they are not caught unawares and we are also not maltreated because they have not been uh, taken into the loop. So the first thing will be, when is the code blue activated in the hospital? It is the code blue is activated by the people who are absolutely on the front lines, as Dr. Kocher said in the morning. And uh, as soon as somebody, usually the patient's relative will run to the sister or the doctor on duty and he'll say something has gone wrong with my patient. Can you come and have a look at the person? So the person who the healthcare provider who goes to the patient while going towards the patient takes care that the scene is safe for him or her by just tying the gown properly, pulling up the mask and uh, wearing the gloves and so on. And so that, we all healthcare providers, excuse me, have to be extremely careful that we do not get caught by being unsafe at the time we are trying to help others. The person who goes to the patient, the healthcare provider, then checks the responsiveness by facing the patient, tapping on the shoulder and shouting loudly the name of that person. And if the person is unresponsive, he or she immediately presses the button. Usually there is a button which alerts the code blue, or there is a specified number in a hospital, which is a code blue number, which is dialed, and the code blue. And remember, the code blue is a team of doctors who are designated on that particular day to attend to all calls for resuscitation. So alerting code blue means you have alerted all those people. Their pagers will sound and they will be given the location of the problem that has occurred, right? So before we go further into what the code blue team is going to do, it is always important that each one of us knows what are the individual skills of code blue. Only when all the team members of the code blue and the assessors, we all of us who do the checklist checks of the code blue at various centers, I feel that the people who are attending this webinar and all of us are extremely important links in that chain who ensure that the standard of care around the country is the same and it is of top order. So I have a lot of faith and I feel that all of us have a lot of responsibility in putting across these skills to you. So the skills of Code Blue are that the person, the code team itself reassesses the scene safety, reassesses the responsiveness when the person reaches that place. We'll go into the details of each one of these as we go along. Then performs high quality cardiopulmonary resuscitation, which is the CPR, which has three main components. Once you have assessed that the person is not breathing and doesn't have a palpable pulse, carotid pulse, goes on to high quality chest compression and opens the airway and provides breath, which again we'll be going into the details of. As soon as an AED, which is an automated external defibrillator or automatic defibrillator for simplicity, or just a machine to give shock, or a defibrillator is available, it is used, which again we'll be going into the details. And then the advanced team joins in and it performs the advanced cardiorespiratory life support as soon as possible, and as soon as they are all there and the things are available, while trying to get the person out of this unresponsive state, which is called the return of spontaneous circulation, or ROSC. Or once the patient achieves ROSC, the patient is handed over to post-arrest care to an ICU team. So these are the individual skills of Code Blue. And as I said, we will be going into each one of them in detail. So the first part, as you saw, was reassessing scene safety and reassessing responsiveness, and thereafter the high quality CPR, which I have told you is made up of these three components. But as I said before, jumping on to the high quality CPR, we will be reassessing and maintain safety at all times. At the moment, we are all inundated by the messages, the reports and activity and guidelines and advisories about how do we keep safe in the times of COVID and so on. But we as a team, all four of us, Dr. Atul himself and the whole team of NABH, I'm sure we have been taking care that each of the lifesaver or life supporter or our doctors or healthcare providers stays safe while managing their patient at all times. Because every year, a lot of us fall prey to this situation that we do not take care of our safety. And when we say talking about maintaining scene safety, it is taking care of personal protection. It has the PPE has become the in thing, the in word, the in phrase nowadays. But let me share with you, and I'm sure all four of us and five of us will be able to say that and confirm that telling people to remain safe while managing the patient, the rescuer's safety. We are the rescuers most of the times, luckily, but we can be the victim also at any time. But at all times, the people who are trying to rescue the patient must stay safe. And that doesn't mean PPE in the terms that we are seeing it day in, day out nowadays with the PPE suit and all. Even on a daily basis, thinking that any patient can be infective, if we are a part of the Code Blue team on a regular day, non-COVID day, we must be wearing our gowns. While we are going towards the place from where we have got the call, we must pull up our mask. We must change our mask if depending upon the patient that we are talking about, or we don our gloves and pull our caps properly. That is what is meant by scene safety in Code Blue situations. And it can be done on the way. It should be first in our minds, and then it will come into practice. And that is very important. And once we reach the place where the patient is lying, we must ensure that the scene is safe for the victim to continue our Code Blue procedures at that point of time. Right? So that is what is meant by maintaining safety at all times. Now, the next thing that we go on to is continuing with the skills of high quality CPR that I was talking about. And to discuss that with you, I'll hand you over to Anil, Dr. Anil Mishra.
Thank you, Dr. Rakesh. Good morning, ladies and gentlemen. To come to this, when we talk about or deal with a collapsed patient, we talk about a patient who's collapsed and who's lying down. So very often you will have a patient outside of the hospital situation, lying on the floor or in the hospital on the bed. So the patient is on usually a flat surface, preferably a firm surface, right? Now, to assess breathing and pulse, what we need to do is we need to look at the patient and assess the patient. So the best thing to do is to get in a position, if the patient is on the floor, to kneel beside the patient, right? And to kneel beside the patient, tilt your head. So put one hand on patient's head. Whenever you are on assessing a patient, you're going to be either on right side or the left side. And there is always going to be one hand towards the patient's head. So use that one hand to put on the forehead, tilt it gently back if there is no contraindication, and tilt your head and look at the chest and the abdomen to see whether it is rising and falling, right? At the same time, with the other hand, feel for the thyroid cartilage, the most prominent part on the front of the neck. Pull your finger towards you, like it said, on your side of the neck, between the muscle on the side, which is usually the sternocleidomastoid, and the trachea. Press gently and feel for the pulse. Now, so you're doing two things simultaneously. You're trying to feel for the pulse, and you've got your head tilted, and you're trying to look for a rise and fall of the chest rhythmically. Now, how long are we going to do this? Not less than 5 seconds and not more than 10 seconds. The reasons are very simple. You don't want to miss out on something which is happening and spend too little time, and you don't want to waste too much time trying to just assess without actually going into action and doing something about this, right? Now, how do we know how much time has elapsed or the seconds have elapsed? So the best thing to do is count 1001, 1002, 1003. So you can do it in English, you can do it in Hindi or in your own language. The idea of adding that word 1000 is to ensure that you do not count too fast and miss out on the time factor, right? The next thing is, once you have assessed that the patient is not breathing and the patient does not have pulse, it is time to get into action. And the thing that you're going to do is start doing a good quality chest compressions. That is the first thing to be started. Now, how do we start chest compressions? So if you move on to the next slide, try and expose the patient's chest. The reason is very simple. You need to be able to identify the area where you're going to do the compressions. And that area usually lies between the two nipples of the patient. Okay, so if you expose the chest, you can draw an imaginary line between the two nipples. And at the center of this is the sternum, which is where the compressions have to be done. Now, once you've identified the area, place the heel of any one hand of your preference, the heel of the hand on the sternum, right? Put the other hand on top of the lower hand, open out the fingers of the lower hand and interlace your fingers and keep the fingers of the lower hand away from the chest. Okay, so that when you apply compression, you do not end up applying pressure on the ribs. Third thing to do now is, how do you position yourself? So above the hand, go to the elbows should be locked so that your arms are not bent, right? Move further up and look at the shoulders. So if you look at this picture, the shoulders are directly on top of the hands. Now in a picture, it is easy to appreciate this, but when you are doing this yourself, how would you know that your shoulders are right on top of the hands? It's a very simple day-to-day life experience that you're going to utilize here. All of you have, at some point or the other in your life, tried to close an overstuffed suitcase. And you use your hands and you shift your weight forward till you feel all your weight is falling on the suitcase. This is exactly what has to be done, except that the hands are here together. Move your weight forward till you feel all your weight is falling directly on the chest. That would be the correct position, right? So you have positioned yourself, your hands are in position, your elbows are in position, and your shoulders are in position. You're ready to start the compression. Now, there are 4 very important things about compression. So the key words are push hard, push fast, allow complete recoil, and minimize interruptions. Now, let me explain this very quickly. When you say push fast, it means you push at the compression rate of about 100 to 120 compressions per minute. All right. But you do not carry on doing all the compressions in one go. In one go, you're going to do 30 compressions at the rate of 100 to 120 compressions per minute. Now, if you do it, the compressions at this rate, it usually takes about 15 to 18 seconds to complete 30 compressions. How do you keep a count? So while you're compressing, just keep counting 1, 2, 3, 4, 5. You drop the 1000 here, all right? So that will give you the rate. The second thing is just how much do you push? Push hard. And when you say push hard in an adult, you push the sternum down by 2 inches or 5 centimeters. All right. But at no time you should push down more than 2.5 inches. All right. Now we have in the present day feedback devices which are kept on the sternum, and you push on top of that is interposed between the hand and the sternum, and you apply the pressure on top of that. Now these feedback devices actually tell you whether you're pushing to the right depth or not. If you're pushing too little, it will tell you too little. If you're pushing too much, it will tell you that you're pushing too much. So those are very useful devices. So push hard, push fast there. Dr. Rakesh is showing this to you. Yes. Just take a look. So this is the flat device which is kept on the chest, and you put the hand instead of directly on the sternum on top of this device. All right. And you do the compressions, and the pressure is transmitted through this device onto the sternum. All right. I hope you understand that. Right. So you've pushed hard, you've pushed fast. Now, third thing is allow complete recoil of the chest wall. When you're squeezing the heart, you push the blood out. Then you have to take your weight off to allow it to refill, so that when the next push comes in, you are able to push a decent amount of blood again into the circulation. What is important here is to remember that even a good quality chest compression pushes out only about 1/3 of normal cardiac output. So no compromises here. Allow it to fill nicely, allow it to be squeezed nicely. All right. So allow full chest compression. And when we talk about minimizing interruptions, we are talking about interruptions in chest compression. And where do they come in? If the patient is not breathing and the patient is not having any pulse, you're going to give compressions as well as breaths. So when you stop compressions and give breaths and come back to compressions, that time span should not exceed 10 seconds, right? So this is to minimize chest compressions, the interruption in chest compression. Now I'd like you to see all these features in this little video that we have for you. Observe closely, please. Right? The chest is being exposed. The hands have been placed in the intermammary line. Look at the position of the hands. Look at the position of the elbow. All right? Shoulders right on top. And a good rhythmic movement of the hips. It's actually a rocking movement. All right? And at one point of time, they used to say, if you can remember the song Staying Alive in your head and you sing it and you do your compressions to that beat, you will get a chest compression rate of 100 per minute, right? I think there's a bit of an interruption happening here. Look at this again.
I thought you were going to sing with it.
No, difficult to keep rhythm because there is an interruption in this. But I think you realize, so you can all choose your own song and sing that song in your head while you do the chest compression. This is like walking to music, and one doesn't get tired easily. All right. So chest compressions, 30 compressions like this, and you pull your hands off. Right. Now, after you've given 30 compressions, it is time to give breaths. What is important to remember here is to give breaths, you have to have the patient's airway open. How do you open the patient's airway? It's a very, very simple method. No special techniques. The procedure is called head tilt and chin lift. Remember, you had kept one hand on the forehead right in the beginning when you're checking the pulse. So you take the hand back into that position, all right? Take the other hand, hook your index and middle finger and hook it under the bony part of the chin. Now, tilt the head back with the hand on the forehead and bring the chin forward. In this case, if you look at it, bring it up with the hooked fingers, all right? Now, when you do this, the airway which was closed, this is just like a situation where a person snores. The tongue falls back, epiglottis falls back. When you do this, the person stops snoring, which means the airway is open. So now, you look at the fingers, which is hooking under the bony part of the chin. It is pulling the chin forward and tilting the head backwards. So if you notice, the jaw and the front of the neck has become stretched. All right, this will open up the airway. Okay. Next thing is now the airway is open to give breaths. There are several methods of giving breaths, but we will just talk about the basic principles right now. When you give breaths during a cardiac arrest situation, after 30 compressions, what is recommended is you give 2 breaths, which means 2 inspirations and 2 expirations. Now, it is very clear that the inspiration should not be very long nor very short. So 1 second each. And how do you know it's 1 second? You count in your head, you say 1001, and you give a breath. All right. And then allow the breath to come out for another 1 second. Okay. So you do 2 such cycles. Now you might have inside the hospital, you may have an oxygen, you may not have an oxygen. What is important to remember is that irrespective of whether there is oxygen or not, the duration of inspiration remains 1 second. All right. Okay. Now, how do you know that your breath has been delivered? So when you tilt your head, you can look at a visible rise of the chest. The chest should rise and the chest should fall. with your breaths, inspiration and expiration. That will tell you whether your breath has been effective, right? Now, you might have a situation whether you have given a breath and the chest hasn't raised. Now, what that means is that there might still be an obstruction, or the seal that you have made to give a breath is not adequate. So you reposition the head again and try and give another breath. All right. The second scenario is the second breath goes or the second breath doesn't go. In either event, you don't waste time on trying to give a third breath. You go immediately back to compression. So now this cycle should not take more than 10 seconds. So within 10 seconds, you complete these 2 attempts at giving breaths and go back to chest compression. Okay. Now, in a hospital situation, and particularly now that we're talking about a code blue team, the best method or the simplest method available inside the hospital is what we usually know as an AMBU bag, which is actually a trade name, but it's a bag mask device. You can see Dr. Rakesh is holding up for you. This is a bag with a mask attached to the front of the bag. So it's called a bag mask device. This is the best method or the recommended method to give breaths. If, however, you're outside the hospital, you would not have a bag mask with you. However, you can have, as a healthcare provider, a device called a pocket mask. This is a pocket mask which Dr. Rakesh is showing you. It comes inside a case. It's a triangular structure. It is usually collapsed. You open the box and you take out the mask. Yeah, we will show it to you again. But this is something which can be carried easily. And I've actually carried it in my pocket on occasions. And I always carry it in my bag. So do the rest of us. Okay. So inside the hospital, bag mask. Outside the hospital, mouth to mask. So we'll talk about bag mask device. You can see very clearly that there is one bag on one side and a mask on the other side. Now this bag is self-inflating. It is open at both ends. One end, the air goes in, the other end, the air goes out. And the mask is fitted at the end where the air goes out. All right. So every time you squeeze it, it reinflates. Okay. So this is called a self-inflating bag. Now, how do you give breaths? With a bag mask device, the person who has to give breaths has to position himself or herself at the head end of the patient. All right. And then place the mask over the victim's nose and mouth. The mask will cover both nose and mouth. And how do you hold the mask in place? Now, this is something which you can see very clearly. The thumb and index finger of the hand, which is holding a mask, form a C. All right. Now you hold the mask with that C, and with the C, remember, you can compress the mask on the face. All right. Now you're left with the other 3 fingers which form an E. Now these 3 fingers which are forming an E go onto the bony part of the jaw on the side, or the mandibular ramus, as you know scientifically. Okay, so you have an E and C grip on the mask. The mask makes a seal. With C, you compress the mask on the face, and with E, now you're going to elevate the jaw. The reason is, with elevation of jaw, the airway is going to open. All right. Now tilt the head. So this is what you have done. You've now done a head tilt chin lift with one hand, with the C and E. All right. So the airway is now open. The seal is made. And with the other hand in which you're holding the bag, you're ready to deliver a breath. And you use the same principles to deliver a breath. You squeeze the bag for 1 second. You squeeze the bag enough to look only for a visible chest rise, not too much. It is easy to get excited when the chest rise is happening. All right. And deliver too much breath, which is not necessarily a good thing, as you can see in this video. I hope we are able to run this here. Look at this. All right. Look at the lungs inflating. But there is something else inflating below the lungs. You can recognize it easily as a stomach. And this is happening because look at the bag. The bag is being squeezed too much. All right. So when you squeeze the bag too much, the air not only goes into the lung, but it tends to go into the stomach, and it can lead to regurgitation. So just a visible chest rise is all that is required. Okay. Right. And now to get back to the cycle. So we are in a situation where a patient has had a cardiorespiratory arrest, which means he has no carotid pulse and he has no respiration. So you started cycles of CPR, right? So very quickly, code blue has been activated. The team has rushed. It has reassessed the scene safety. After reassessing the scene safety, it has reassessed the responsiveness. The patient might have recovered, all right? If the patient is still not recovered, then they check the pulse and breathing for 5 to 10 seconds. If there is no breathing and there's no circulation, remember to start with chest compression first. So 30 compressions followed by opening of the airway, giving 2 breaths, and then going back to 30 compressions. All right. So this cycle continues. All right. 2 breaths and 30 compressions. The question is now, how long does one continue? All right. You continue it till patient shows some signs of return of spontaneous circulation, which would be that the patient starts breathing, patient starts moving, groaning, etc., etc. All right. Now, if there are 2 people, how do you carry on with improve a good efficiency of the team? So the roles get divided. So the person who's doing the hard work, that is chest compression, will after 5 cycles or 5 compressions of 30, 5 cycles of 30 compression and 2 breaths, will go on to giving breaths. And the person who was giving breaths will now start doing chest compression. How do we do it? Now look at these two, identify these 2 rescuers. Person A is doing chest compression and person B is giving breaths, right? After 5 cycles of 30 compression and 2 breaths have been completed, the person A has now started assessing for signs of circulation now because he's free. He can check the carotid pulse. So he's checking the carotid pulse. It is not mandatory, but it is something which can be done easily. He can make good use of his time. So he's looking for carotid pulse to see whether the spontaneous circulation has returned or not. Now the person B, after giving the 5th cycle of breaths, quickly leaves the bag aside and moves to the new position on the side of the victim and starts chest compression. The person A now moves to the head end, picks up the bag, and now this person is ready to give breaths. So because the compressions have to always start first, so the person who's to start compression always moves first. And the person who has to give breaths then replaces that person. So this cycle of switching between A and B after every 5 cycles of 30 compression and 2 breaths will continue. Dr. Sunil?
Yeah.
It's time to go on to the next step, please.
Thank you. So as Dr. Mishra has said, with the best of the compressions, best of the cardiac compressions and the breathing, you can take care of the cardiac output only by 30%. Now, what to do about the rest approximately, because normally it has to be near the 100%.
Sir,
Right?
Dr. Sunil, sir, there's a small request from people that if you could speak a little louder.
Yeah, I'll repeat. As Dr. Mishra, is it audible now? Is it all right? The coach is all right?
Yes, sir, I think so.
I think
Okay.
Yes, sir. Yes.
on your laptop also you can increase the volume sometimes.
I think it's the maximum.
Okay.
It's maximum.
I think it will be fine now that you are holding it close to your.
Correct, sir. Correct.
Yeah. Yeah, as Dr. Mishra said, with the best of the cardiac compressions and giving breaths, you can take care of only 30% of the cardiac output. How to bring it to near normal? That's 100%, right? So before we discuss that, let's understand what happened in the sudden cardiac arrest, the video which I showed you, right? This is a normal heart. Sir, can we see the video? Yeah, which is normally breathing absolutely all right, lubbed up, and suddenly something happens. It has started fibrillating. So when the heart starts fibrillating, it is consuming the ATPs and no cardiac output. So after a few seconds, what happens? The whole of the ATPs are gone and heart becomes absolutely straight line, no cardiac activity. So with the result, the person collapses. That's what happened in all the 3 cases which we showed you before. Now, how to take care of this, right? If we are the outside hospital condition or inside the hospital condition, inside the hospital, we have got the manual defibrillator where the people get this condition known as ventricular fibrillation. There are experts, there are advanced life providers who can diagnose the ventricular fibrillation and take care of that, right? But in a situation which is outside the hospital or in the hospital where the person are not expert, so we have to have a device which decides whether the heart is having fibrillation or not, because in 84% of the cases of sudden cardiac arrest, this fibrillation is the cause. In rest 16% of the cases, this is not the cause. So to take care of these 84% cases, a device has to be there, which is automated. This automated means every process is automatic. External means we apply the pads over the body. Defibrillator means it gives a shock automatically, right? So can we see the next? Yeah. Now it delivers a maximum amount of electrical energy over a few milliseconds, right? The heart is fibrillating. And when we give the energy from outside, it becomes totally stunned, absolutely straight line. So if you're giving good quality CPR after that, it assumes the normal activity will come back. Right? This is the principle of using defibrillation, giving shock, or the AED. Now, there has to, how we know that and chances of success drops every few minutes because it is consuming the ATPs. So this has to be used ASAP, that is as soon as possible, right? Now, how we know that the cause is the ventricular fibrillation or some other causes, right? So there has to be connection between the device and the patient, right? So what are the operations of the AD? What are the steps? The first of all, switch on the machine, right? This is totally automated. So as soon as you switch on the machine and follow the prompts, and just follow what the machine says, right? And this is power. After having the power on the machine, the next step is the prompt says apply pads to the patient bare chest, right? So we apply pads while the cardiac compression is going on because, as Dr. Mishra said, there has to be a minimum interruption, right? After the pads, where the pads have to be attached, it is all depicted on the pads where they have to be put, right? So as soon as the pads are attached, the machine will automatically analyze the rhythm, whether it is shockable rhythm or non-shockable rhythm. At that time, when the machine is analyzing, you have to be little away from the patient, right? Because otherwise, when you're doing the cardiac compression, the machine may think that it is a ventricular fibrillation where it is the straight line, right? And after the machine has analyzed, it normally takes approximately 10 seconds to analyze a good machine. After that, if the machine says that, okay, it is the shock is required, just press the button, right? And after, again, you have to be away from the patient because otherwise you can get the shock. So as soon as the shock is delivered, with the machine will automatically deliver, start the cardiac compression. Again, give the 5 cycles of 30 compression and 2 breaths. That approximately takes 2 minutes. And after that, again, the machine will automatically say, analyzing the rhythm and whether shockable or non-shockable. So as soon as the AD arrives, it checks for the rhythm. If it says shockable, when shock is delivered, and you resume CPR and give 5 cycles of CPR, good quality CPR, right? And again, analyze the rhythm. Again, go back to the check rhythm, right? It was a non-shockable one, which approximately is there in 16% of the cases of sudden cardiac arrest. You resume CPR immediately, give 5 cycles, check rhythm after 5 seconds, because initially the rhythm may be non-shockable, but after good quality CPR, the rhythm can be converted into shockable. As you probably I am able to highlight, a shockable rhythm is much better than the non-shockable rhythm because it is the causes of ventricular fibrillation. You are given the shock. The first shock usually converts approximately 95% cases of ventricular fibrillation into the normal sinus rhythm. So that is the importance of the AED. And AED, the shock has to be given as early as possible, usually within the 3 minutes, because after that ATPs are consumed and it becomes the non-shockable.
Do you want me to show the AED?
Yeah. Sir, I am not able to see the screen. You can probably demonstrate.
You can't see the screen?
No, I can't see. I can't see.
So
you can demonstrate, sir, if everyone is able to see.
So this is the AED, one of the AED machines, which is there. There is an on-off button out here. As soon as you press this button.
Unit, okay. Stay calm. Check responsiveness. Call for help. Attach defib pads to patient's bare chest.
So these pads, as Dr. Sunil has told you, are to be attached onto the patient's chest at the positions which are shown on the pads themselves. I can't show because it will slide down on the mannequin, which is right behind me. But once you have attached the pads,
don't touch patient.
It will say this.
Analyzing. Don't touch patient. Analyzing. Shock advised. Don't touch patient. Press flashing shock button.
I hope you can see the flashing shock button. This one. So press this.
Shock delivered. Start CPR.
Now you can hear the metronome, which will guide you as to how many compressions are to be given at what rate, right? So this is the functioning of AED in short. Dr. Sunil, is that fine?
Yeah, so I'm not able to see. So what I heard is perfect, sir. That Kocha will be able to tell in a better way because he's able to see.
Sir, we can
Dr.
clearly see. If you can just adjust your setting now, Dr. Sunil sir. I think you can open that grid, so you will have picture in picture there.
I'm able to see you. I'm able to see Dr. Mishra. That is all. In the screen.
Maybe
Okay,
you can scroll to the next slide.
I think he has to go on the
Yep.
that there are two modes which are there.
Okay, sir. It's all right. It's all right. It's all right. We can
where
continue.
you can see more than 4 people.
Okay, sir. We can continue.
Anyway,
So I think it reminds us of the very important personality, our ex-president, who was perfectly all right giving a speech and he collapsed. The normal reaction is take the patient immediately to the hospital. And by the time one reaches the hospital, usually the response is, Doctor Sahab, late लेके आए. I think it's a little late, right? The best thing is let the hospital come to you. If in the hospital condition or outside the hospital condition, start CPR, good quality CPR immediately so that it maintains the ATPs. And as soon as the AED or the defibrillator comes, use it. Am I right, sir?
I think, Dr. Sunil, you can share your experience that the OPD block has 5 AEDs installed in our hospital at 5 floors. And because there is a footfall of more than 7,000-8,000 people out there, they are within the hospital premises, but yet not in the wards. So there the AED is a great help. And all the airports, a few metro stations, Duronto Express, aircrafts, so many places. And our friends, our assessors, our seniors who are attending this webinar, they must have all been there. They must have faced such situations. And once they know how to use it, how simple it is, I'm sure that each one of us can matter to one life in our lifetime. And that's
absolutely great. And some important lives have been saved. It has been on record. And there in medical college, they saved one person who collapsed at the gate of the hospital. And the team rushed with the AD there, right? And given a shock, the patient, there was a recovery, there was spontaneous circulation, and the patient went into the CCU, they did the angiography and all that, and the patient discharged after 9.
I think in 15, 16 years, that is the first incidence where we heard that the AED was used just outside the hospital, and it actually ended up in a neurologically intact old person. He was around 60 plus person, you know. So
because the window is very small. If AED has to be used, it has to be used in first few minutes. After that, it's too late. After it becomes the standstill hold, ATPs are consumed, you cannot do anything, right? And a good quality CPR, of course. Absolutely. It has to start as early as possible.
So do we go to the next slide?
Yeah, Dr. Shakti, can you tell us something about it?
I can remember the incidents which was quoted widely in the press, that the president of the American Heart Association, who was a cardiologist, he had a sudden arrest at 6 a.m. in the hotel during a conference. And there was his daughter who tried to resuscitate him, and AED was available in the hotel, and it was immediately available to them. Within 3 minutes, the AED was applied, and he was successfully resuscitated and all intact. So that is one thing which is certain, that the AEDs can save the patients. More AEDs at more places are available, more lives will be saved. And as soon as we apply the AED, the chances of survival keep on decreasing. If you do not apply, say, every 7 to 10% chances decrease every minute. So if you do not apply AED for, say, 5 minutes, the chances are that only 50% of the patients will be revived. That is just I wanted to say.
The example that I have is the person, our friend, my classmate, who collapsed at the just close to the one of the cardiac centers in Delhi, and by the time he received his first shock, and mind you, the rhythm was a shockable rhythm. It was 18 minutes, But even that could not help, because as Dr. Shakti is saying, in the absence of good CPR, every minute the chances go down by 7%. And in the presence of a good CPR, they go down by 4 or 5%, isn't it?
Yeah.
So I think Dr. Sunil can summarize the special features at the special age groups and other conditions. Right, Sunil?
Dr. Shakti is expert in that, sir.
Okay.
So we use AED in all age groups. We take adult a person who's more than 8 years of age. If the person is 0 to 8 years, we take it as a child. In a child, we preferably use child pads and child system. In an infant, we may use a child pad, we may use adult pads also, and whatever is available. But remember that the child system with child pads cannot be used in an adult, but adult system and adult pads can be used in a child. But you have to see that the pads do not overlap. So best thing is when you are putting pads in a child or an infant, you can put one in the front of the chest and another in the back of the chest. So that the heart gets interposed between the two pads. The idea is that the current should flow through the heart.
I
Now,
think, Doctor, you can talk about the hairy chest and wet chest and
yeah,
the medical patches and other things as well.
there are victims who have hairy chest. Now, if there is a hairy chest, the pads don't fix properly. So what you can do is that sometimes a razor is available in the AD kit. You can clean the shaven the only the part where the pads are to be stuck quickly. You can shave that and put the pads. If there is no razor, usually two sets of pads are available. You can put one set of pads, forcefully remove that pad, and which lots of hairs will also come out, and then you can put a second set of pads. So that way, the hairy chest is taken care of. Now, there may be some situations when the victim is lying in the water. Maybe the patient has had drowning and he is just out of it. He has an arrest, which is a shockable rhythm. In that condition, you have to just wipe off the front of the chest. Don't wipe out everything. Just front of the chest can be wiped, and you can put the pads at that point in time. This water can also be there. Suppose the patient has an acute myocardial infarction or uh, ST elevated myocardial infarction, he has lot of perspiration. So that will also cause lot of wetness on the chest. So only the front part of the chest can be wiped out, the area where the pads are to be stuck. So that is cleaned, and then you can apply the pads and then go usual as Dr. Sunil has already told you. Then there can be situations where the patient has an implanted defibrillator, which will be looking like a about 1 to 2 centimeter bulge on the chest. Usually it is on the right side or on the left side. Now you have to avoid this bulge and put pads about 2 to 3 centimeters away from that. If it is an internal defibrillator might be working. You might be seeing some twitchings on the skin on that part of the bulge. Let the internal defibrillator work if it is working, and then you can use the AED afterwards. But if it is not working, you can use the AED straight away. Then some people are using the patches. Maybe somebody is using nitroglycerin patch, or somebody is using analgesic patches. So if that falls within your area of the pad, then you can remove those patches, wipe out the area, and then you can put the pads. So these are some of the situations in which we have to use the AED carefully.
So, Dr. Shakti, not only the aid is important, but probably proper training in the use of aid is also required. And that, I think, not more than half an hour the training.
Yeah, some training is required, and AED is very simple to use. What you can do is take it as your spouse. If you don't follow it, they will continue to say okay, yes, continue to do this job. You have not done this. You have not done this. So unless you do that job, the AD will continue to say, yes, do this, do this, do this. Follow the prompts of the AAD religiously, and I'm sure that the patients will be saved. Sir.
So, Dr. Shakti, you were to discuss these
Yeah.
more code
Then
blue
there are
situations.
some more code blue situations in which the code blue is activated. The patient was unresponsive. The code blue is activated. You have reassessed the scene safety. You have reassessed the responsiveness, and you have assessed the breathing and pulse. Now you have found that the patient is unresponsive, but he has normal breathing and has a pulse. Now in this situation, this can be found if the patient has drug overdose, the patient is unresponsive, but he is breathing normally. Normal breathing means that the patient has normal breathing. Any abnormal breathing, we will take it as an absent breathing. Now this person has normal breathing and pulse, so we have to put him in a recovery position. Now this recovery position is the left lateral or right lateral position, whatever you feel like. Now in this photograph, if you see that the head is tilted a little back, the head is supported on the upper hand of the victim. The lower hand is at a rectangle, which is making the patient not prone, and the bent arms are giving it a stability. Now the upper part leg is bent so that the patient does not become fully prone, and the lower leg is straightened. Now this is the position which we used to do sometimes after the tonsillectomy also, so that any secretions, when you see, any secretions will come out through the angle of the mouth. The trachea is above the angle of the mouth, so all secretions will trickle down through the angle of the mouth, and the patient's airway will be maintained. Now we can check breathing every 2 minutes. Anytime the patient has stopped breathing or has no pulse, we can just straighten the patient, and what Dr. Misra has already told you, the chest compression, we can start. Now there can be situation also when breathing is absent but circulation is present. This you will frequently find in ICUs where the patients are on ventilator. We are supporting patients the breathing, but patient circulation is intact. So what we have to do, we have to just support the breathing. So give breath which is at the rate of 10 to 12 breaths per minute, and continue to monitor circulation every 2 minutes. Now these are the special situations. Now we have a word about out of hospital situations. These are the situations which were in the hospital. Then we have some situations which are out of the hospital. Now if you are a lone rescuer, ensure that the scene safety is there. You have to always ensure scene safety, as Dr. Rakesh has earlier told you, that scene safety is one part which you always maintain. Then after that, assess the responsiveness as soon as possible and make an emergency call if the patient is unresponsive. Then you assess the breathing and pulse within 5 to 10 seconds. It should not be less than 5 seconds and not more than 10 seconds. Once the breathing and circulation is absent, you give 30 chest compressions, and you have to decide at this point of time whether you want to give breast to the patient or not. If you want to give breast to the patient, then you open the airway and give 2 breaths using a pocket mask. Now, if you are not comfortable in giving breast to the patient and you are a lone rescuer outside the hospital, you can continue to give chest compressions without giving breaths. This is an outside the hospital situation. If you do not want to give breaths, you continue to give chest compressions, and the chest compressions rate is 100 to 120 per minute. That means you will continue to give about 200 to 240 compressions in 2 minutes, and then only you'll check the signs of circulation. Now, once you have seen, you have started trying to give breaths using pocket mask. You have to use a barrier device, and pocket mask is a good barrier device which is available now. It is opened like a jewelry box, and it has contents which have a spirit swab, a pair of gloves, and a pocket mask. It is easier to assemble. When the pocket mask is there, you can see the white structure, which is a hydrophilic. It doesn't allow the secretions to come to the rescuer. Now you push that area and it will open up and tell you that it is it has opened like a pocket mask. Now you can put a unidirectional valve. The valve will fit only in one direction, and this will be a unidirectional valve which will give breath to the patient, but the patient's expired breaths will not come to you. So this is a safety device and a barrier device. Now, how do you use a pocket mask? It's a triangular structure. The apex of the triangle will go to the gravula or to the bridge of the nose, and the base will come to the chin. Now, how to hold it? You have done the head tilt and chin lift earlier. Now the thumb and the index finger were free. You make a V, inverted V, and make a tight seal over the V part of the mask. That is the apex. And the chin, you use 2 fingers, and the thumb of the other hand goes to the pocket mask and makes a tight seal below. And then you are able to head tilt and chin lift and give 2 breaths. So this is how you use a pocket mask. We'll show you how the pocket mask works. So made a V and thumb down and give 2 breaths. 1 second inspiration, 1 second expiration, and again 1 second inspiration. So this is how we are using pocket mask. So if you are a healthcare provider, I think you should have a pocket mask with you. You can keep it in your bag. You can keep it in your pocket, which can be readily used. It's a very small pocket mask which can be used, as Dr. Rakesh is showing you. Now, this was a situation when myself, Dr. Sunil, Dr. Misra were walking in the Maulana Azad Medical College, our lawns, front lawns, and Dr. Misra was talking. He's a very talkative person.
Dr. Shakti, we shot it for the Delhi Doordarshan.
Yeah.
We shot this video, yeah? We simulated the situation.
He simulated the situation for Doordarshan, and you'll see how Dr. Misra has acted beautifully.
As Dr. Atul was saying in the morning.
Yeah,
Dr. Atul
absolutely.
was saying that he's a very good.
And this is the just on the Dean's carpet, as we call
Yes.
it, sir, at
Yeah,
the famous
Dean's carpet.
Mamsi, and we can see the
Yeah.
Mamsi gate behind you.
Yeah.
Yes. And this video always reminds me that the people who are walking around, none of them actually came to help. Anyway, so let us look at the video.
So
Does this have a audio also, sir?
No.
No. Okay.
So he felt little uneasy and collapsed. So we gently lowered him to the ground, checked for the scene safety, everything is safe. The people are walking around, nobody is bothered. Checked for the responsiveness and called for help. So Dr. Rakesh dialed the casualty emergency of Loknayak Hospital. We checked for the pulse and breathing simultaneously, and since there was no pulse, we started with the chest compression. So in the meantime, Dr. Rakesh had a pocket mask which was given to me, and 2 breaths were given. You can see the rise in chest, and again 30 compressions are given. Meantime, the ambulance from Lok Nayak Hospital has come, and Dr. Sunil has brought the AED. So while he is opening the AED, we'll continue with the chest compressions. Okay? Till the pads are applied.
I think this video beautifully highlights that minimizing interruptions at all times in chest compression, the importance of scene safety, whatever way it can be done, even in the field. We were talking about within the hospital, but outside as well. And using the AED as soon as it is available on the site. No, Dr. Sunil?
Yes, absolutely. Absolutely.
So,
and so start the good quality CPR ASAP as early as possible and call for the help.
So lives can be saved by using an AED and good quality chest compression.
So having completed the basic life support, the part of Code Blue, let us in short discuss about the advanced life support limb of the Code Blue, because the Code Blue starts with a small team coming in and starting with the basic life support steps, keeping in mind that the scene is safe for everybody. As the advanced team joins in with the code cart, which can have, as Dr. Sunil has talked about, manual defibrillators, drugs, fluids, IV fluids, etc. The team joins in, and an advanced assessment and management of the patient is now carried out. The BLS is continuing at the same time. The code team is the team on duty on that particular day, and when the code blue is sounded, they come in, and at the same time the code cart, which carries the basic and advanced assessment and management things, are brought to the site where the patient is being resuscitated. The way the outcomes of the victims' problems is totally dependent upon how the team works, and we have realized that the better the team gels, the better the team knows each other's steps, the better the team knows each level of the skill, the better they perform. And of course, on a particular day, one of the team members becomes the team coordinator. Rather than using the term leader, we use the term coordinator, because that person on that particular day, and again, it is irrespective of the level of seniority of a person. The first lifesaver, the first life support team member who reaches the site, he or she should be the team coordinator on that particular day. So the team coordinator does the first thing, he or she takes care. And before I go any further, I must tell you that an ideal team is of 6 people, but at least 3 people have to be there to conduct an advanced code, right? So if the coordinator does the first thing, he takes care that all the team members are safe, they have taken care of their personal protection, and at that time he or she analyzes or checks the responsiveness of the patient, makes the initial assessment, and then, because everything is available now at that site, starts giving the role, allocating the roles to the team members. The first person is sent, as we were doing call for help and AED. Here also, he tells the first member of his team, go and get the code cart, attach all the monitors to the patient and tell me the condition of the patient, tell me the vitals of the patient, tell me the parameters which you find. So the first person gets the code cart and starts attaching the monitors and all the equipment on the patient. While this is being done, the second person is immediately sent to assess the pulse of the patient, the carotid pulse, and if the pulse is not there, start with a high quality chest compression, as we have been talking about. So the second person, because we are code blue, we are already presuming that the patient is in cardiorespiratory arrest. That is what the code blue is for. The second member will go and check the pulse and will reassess the pulse and will start chest compression thereafter, after checking for the pulse, that ensuring that at 5%, 10 seconds, that there is no pulse. Start with the chest compression. The next member of the team is sent to the head end of the patient to open the airway and start giving breaths. And if the oxygen is there, connect that oxygen to the patient. While all this is being done, the person with the monitor and code card, defibrillator or AED, whatever, is bringing the things and attaching it on the patient. If we have more rescuers, then the next rescuer will put up an IV line, will draw the samples depending upon what we are thinking in terms of the diagnosis, why the patient is in cardiac arrest, and manage the drugs and fluids thereafter as the code is being run. And if we have 6 persons, which is an ideal situation, the 6th person takes care of the records, which of all the activities which is happening here. And you can see the arrangement of 6 people. The coordinator has moved to the foot end of the patient, from where he or she can easily see all the activity which is going on and can address each one of the team members. At the same time, the record keeper, the M5, is close to the coordinator. This person can be also at the head end, and the two are the ones who take an overview of the situation and keep on recording. The M5 keeps on recording while the others are doing their activity. And at this point of time, for a team to work properly, as we say, as a well-oiled machine, it is important that each one of them knows the various elements which are very important, which form the team. You say this is a formidable team. Individually they are not that good, players, but when they blend as a team, they are unbeatable. They are world beaters. So similarly, the resuscitation team should be such that they know the elements of team dynamics, and they actually live those team dynamics, so to say. The roles, so these dynamics can be divided into roles, into what to communicate, and then how to communicate. So these 8 team dynamics are applicable to any sphere of life where you are working as a team, especially when you are working with your peers. When you are working with the people who are too much senior to them, then you tend to listen to them. If you have too many juniors, you feel that they will listen to you. But the team is one where it doesn't matter which level of seniority you have, but you are following the team dynamics. So the roles, as I said, which are there in a team are clear roles and responsibilities. That means whichever role is allotted to you. Dr. Shakti is the coordinator of this webinar. So he was the one who allotted us that this is your role and this is your role. And at the same time, so there has been constructive intervention in these roles. So whatever role is assigned to you, you must understand that role and say that, yes, I am going to do this role, and I'll put all my mind, heart, soul into the role which is given to me. The team coordinator also has to understand which person of his team will be the best suited for a particular role. So accordingly, he or she should assign the roles. And then the person who is being assigned the role should know that this role is not the one which he or she does very well. So he should be, without shame, immediately share it with the team coordinator that, okay, this is something which I'm not very comfortable with. Can you assign me some other role? At the same time, the team leader sometimes may be leading a situation where he himself or she himself doesn't feel comfortable. A code which you have never done, you and Sunil has done, let us say. So I'll say, Sunil, can you lead this code and tell me what to do? So I get a great chance to learn from the best person at that point of time. It is not just because I am the senior most or I am the first person who has seen the patient for the first time, I have to lead the code. So this knowing your limitations and without any shame accepting it saves the lives. So know your limitations and admit them so that you can be assigned a different role, or you assign another person as the team coordinator. And constructive intervention is something where, irrespective of the level of your colleagues who are doing something which can harm the patient, you must intervene, and in a manner which is very subtle, very comfortable to the person, rather than be accusing. You don't know this, you don't know that, like this. This is very often seen on code blues. But if the person says that, we are dealing with an adult patient, are we giving the right dose? So this gives a chance to the person to rethink his or her strategy and say that, okay, good, you told me. And we basically, the idea is not to harm the patient. So all these roles are meant in that manner. So these are the roles, clear roles. And so understand your role. If you can't do that role, withdraw quickly and go to the role which you can do well. And if any one of your team members is going to make or take a step which can harm the patient, you have to stop him there in such a nice manner that he or she understands that you wanted to warn him and tell him that something is going amiss or going wrong. Then what to communicate? During the process, one is the roles that we have done. Once the roles are done, we are doing our job. Then what to communicate from time to time? From time to time, we must share our knowledge. That means the team coordinator should loudly say that, okay, we are in such a situation. Are we missing anything? Do you have any good ideas? So what it does, it allows every team member to start feeling a part that he himself or she herself is leading the team. Okay, whatever findings come to their mind, they can share loudly so that every team member understands. A person who is doing a chest compression suddenly finds the chest full of urticaria. He or she has to immediately tell the team coordinator, the chest is full of urticaria. Are we dealing with an anaphylaxis? Great, good, you told me. So this is what is knowledge sharing. Also, re-evaluation and summarizing. Every 2 minutes, the recorder or the team coordinator, if there is no recorder, the team coordinator kind of revises the whole steps that have been happening till that time, so that everybody, as we said in the beginning, is on the same page. The language of resuscitation, which Dr. Shakti talked about. And similarly, if a new person joins the team, he or she should know that we are 8 minutes into Code Blue and this is what has happened. Now, can you take as a role as a recorder? Okay, good. So he or she makes a small summary of what has been told to her, and after that, she starts building up on that story. So that is what is re-evaluation and summarizing. And then finally, how to communicate, how to talk to each other when we are in a meeting, in a Code Blue. The message which we want to give should be clear. I want to tell Dr. Shakti, can I take the next slide and do that? So I should be looking at Dr. Shakti. I should communicate with him, preferably by his first name and respectfully, but the message should be loud. It should be clear. It should not be mumbling. So that is what is clear message. And it should be, unambiguous. Take care of the airway. It is ambiguous. And what do I mean by, do I want him to be intubated? Do I want him to be masked, bag masked, or whatever? So be clear in your message. It should be a clear message, using person's first name, talking with eye contact. Closed loop communication is another very important part of for success of a team effort. And that is, whosoever is given the message repeats the message. Okay, I'll do the next slide. Okay, and I'll do this. Okay, and I have done it. When you have finished that job, I'll give 300 milligram. Please give 300 milligram of amiodarone to the patient and flush with 20 ml of saline. Okay, I'll give 300 milligram of amiodarone and will flush with 20 ml saline. Will raise the arm. So that means whatever has been told to me, I have registered that. I have not heard it wrong. I will not make the mistakes. And once I have completed that job assigned to me, the team coordinator will know that now I am free for the next job to be allotted to me. This is what is closed loop communication. And at all times, we must ensure that we talk in a language which is not hurting. We may be the closest of friends, but when we are working as a team in a group, in a WhatsApp group, in a video chat, in anywhere, the language that we use for each other has to be such that it exudes respect for each other. So if I say, Dr. Shakti, will you do the next slide? Okay, that's very nice. Thank you, Dr. Rakesh. Similarly, thanks, Dr. Sunil, for doing this great presentation on AED. We'll continue from there. Just a couple of messages here and there, which makes everybody happy and finally ends up in a great team effort and outcomes improve remarkably. So that is what is all the 8 components of an effective resuscitation team dynamic. I feel that it is effective team of any kind. So this is one thing which I think all of us, when we check the any team for their activity level and their perfection level, this is something which we must look at very carefully, isn't it, Dr. Shakti? I think you are a master assessor for many years. I think this is one thing which you stress a lot on.
Yeah, the team dynamics have to be stressed because sometimes the assessors are working with the team. There are two assessors, sometimes three assessors.
Okay.
So all these roles and responsibilities and how to communicate and what to communicate, we usually follow. Uh, and we are also working with the hospital concerned, where we see to it that the team dynamics and mutual respect is maintained at all times.
Yes. Okay. So do I carry on?
Yeah.
Okay. So let me summarize quickly the steps of advanced life support. When that advanced team comes, we are already doing the basic life support is carrying on, and the if the team members are now there, which are there, they'll make the primary assessment and management, and will look for the cause why the patient is here, which is called the secondary assessment and management. I'll quickly run through these. The primary assessment is made up of ABCDE, advanced ABCDE, which means the primary assessment of airway and breathing. How is the patient doing now? We had done it by just looking at the chest, count, seeing that the patient is breathing or not. Now we have the monitors with us, we have the devices with us, we have the oxygen, we have monitors with us. So we can assess respiration using the monitors and can start giving oxygen to the patient, and manage this by using advanced airway devices which come right from bag masks we have talked about, but supraglottic airway devices which you can see on the screen, or an endotracheal intubation if required. And all these things, whether they are working fine or not, oxygen is available, and all these are working or not, we can check and monitor by using advanced monitors, which we have at this point of time. The advanced team has it with it. The advanced C, or the of primary assessment, means that we are continuing with high quality chest compression. One thing, that is the core thing. We are using the defibrillator as and when prompted by the defibrillator or AED, but at the same time we are putting the IV lines, we are doing the sampling, and we are giving fluids and drugs as and when required, depending upon the condition of the patient and as guided by the team coordinator. So this is the primary assessment and management which is happening simultaneously while the BLS part is going on. The D part of primary ABCD is now looking at the disability, which is in the form of whether the patient now has become alert, because we started with unresponsive patient, we were in the code blue. Now he can become, when he tends to become responsive, there may be a situation when he is responsive only to deep pain, or just on shouting, or he or she becomes totally alert. So the disability is ranked on the basis of his level of alertness, and then we also rule out whether the patient is in this condition because of a stroke, an ischemic stroke or a hemorrhagic stroke. And we also can at this time assess the pupils of the patient. Till now, we were just bothered about the resuscitation of the patient, and we had not taken a look at the pupils at all, nor was it needed. Now we can look for any neurological problems or disability which is there in the patient. And the secondary or the primary E is expose the patient so that we do not miss out any finding which we had missed till now, which is in the form of a trauma or a bleeding or a burn or unusual presentation or something, or a medical alert which the patient was wearing. So, but remember that we expose it only to look for all these things and clothe the patient or cover the patient so that the patient doesn't remain exposed during the rest of the thing. So this was the primary ABCDE, which is taken care of by the team coordinator or the team member, whosoever is allotted the job. And at the same time, the secondary assessment and management steps come in, where you look for the differential diagnosis. Why this patient is still not recovering? Why this patient has gotten into this situation? and that is simply remembered by sample history. If we have missed any part of the history, one of the team members who is free in between those 2 minutes of compression cycles, the person who is on the monitor can have time and go to the patient and do the sample history, by which we mean the signs and symptoms are reassessed, how the whole is the patient having any allergies, any medication the patient was on, when was the last dose taken, what is the past medical history, which is related especially to this current illness that we are looking at. L is for last meal, when did the patient have the last meal, and what are the events which have led to this situation. So all this is easily remembered by a mnemonic called sample, and so it is called sample history. And at the same time, we look for reversible causes in the forms of H's and T's. These are the H's and T's that we look for, and basically we are looking for a reversible cause. As Dr. Shakti, Dr. Sunil, Dr. Misra have told you, all the high quality resuscitation is all about gaining time for saving the ATPs in the heart, allowing it the best chance to come out, giving defibrillation fast. But at the same time, if we can find out a reversible cause, the H's and T's, and we can reverse that, the chances of the patient recovering and maintaining that recovery become multiple fold. So this is what is the primary ABCDE and the secondary assessment and management stage, which we do during an advanced team being there. So out of the 6 people, 1 person is deputed for some of the activities, and the team coordinator keeps on doing some part of what I talked about. And then, of course, the team person, the team members, the team coordinator should know the cardiac arrest algorithms, right? And that means the person is still unresponsive and the patient doesn't have a carotid pulse. That is that is the area, that is when we call the person is in cardiac arrest. And the cardiac arrest, as Dr. Sunil has very clearly told you, can be with a situation where it's shockable. We had used the AED in that situation, or it is a non-shockable rhythm like an asystole or a PEA. Now, because we are in an advanced center, we have a monitor in front of us, which is showing us whether, and there are people who are advanced life support providers. They can understand, they can identify whether the rhythm is shockable. That means a ventricular fibrillation or a pulseless ventricular tachycardia, or pulseless or a non-shockable situation, which is an asystole or a pulseless electrical activity. There are 2 limbs which you can see of this algorithm: the shockable side and the non-shockable side. Whether the people who are doing the code blue, they know the shockable rhythms, or they are doing it well or not, or they are non-shockable rhythms, which are the 2 at the bottom, the flat line, or very few beats, less than 6 beats with no carotid pulse, that is known as asystole. And the last one, which looks like a wonderful ECG recording, but there is no carotid pulse, that is what is called a pulseless electrical activity. So all code members should be able to identify at least these 4 situations which can be there, and they should not miss out on any shockable situations wherein they give the shock as soon as the shocking device, whether it is an AED or a defibrillator, is available. So this is what the advanced life support side of the code blue is all about. Is that fine, Dr. Shakti? Do you want me to?
Can we elaborate on the how to give, how to find out the rhythm shockable, and when to give CPR, and along with the drugs, what time the epinephrine is given and what time the amiodarone is given?
Okay.
A little about it, because it is an essential part. Whenever we go and visit some hospitals, there are some these guidelines are there, but there are sometimes there are old guidelines. So what is the updated guideline? Can we elaborate on that?
Okay. So so let us go back to the team once again, friends. So the team has come in. The people have been assigned their roles. Somebody has put the monitors, and these are one of these 2 rhythms which you can see on the monitor. And everybody in the team is alerted that we have got a rhythm which is on the top. If you look, this is a ventricular fibrillation, and the lower one is a ventricular tachycardia, but as we said right on the top that there is no carotid pulse. Both these situations are cardiac arrest situations, but these are shockable situations on this side of the screen. So VF and pulseless ventricular tachycardia. So what do we do at this time? The team members are there, chest compression is continuing. So the first thing which we want to do is we want to give shock as early as possible. So we presume that the person has got a defibrillator. So the team coordinator, the person who was on the monitor, he tells that person, okay, let us say Dr. Anil is on the monitor, and Dr. Shakti is leading the charge. So Dr. Shakti says, Dr. Anil, will you please give shock to the patient? Give 150 joules of shock to the patient. So Dr. Anil Misra immediately, closes the loop. Yes, charging. I'll give 150 joules of shock to this patient. Right. The chest person on chest compression. Let us say Sunil was continuing with chest compression. He says, Dr. Sunil, I hope the chest compressions are fine. He says, fine, they are nice. And the person on the airway manages that. So Dr. Misra has charged, and there is a sound of continuous beep which comes on the defibrillator, and that means it is charged. So Anil immediately says the defibrillator is charged, so he applies the gel and makes sure that the gel is nicely spread. The patient's chest is exposed. He places the pedals at the right place, and he presses them down and looks around and looks whether anybody is touching the patient or not. I clear, you clear, everybody clears, looks around, ensures that nobody is touching the patient, giving shock at 3, 2, 1, shock. So he presses both the buttons on both the pedals simultaneously. That is when the shock is delivered. The shock is delivered, and he says shock delivered. So immediately in the meantime, the two people who are giving chest compression and breathing, or any two people, they will shuffle so that the compressor changes after every 2 minutes, as Dr. Misra has told you and everybody has told you. So the chest compression begins immediately after giving chest compression. So after giving shock. So once one shock is given, with the second shock, by that time the person doesn't get reverted to normal and the return of spontaneous circulation is not there, the person is also given epinephrine at that point of time. So the team coordinator tells the person on the IV line that get ready with the epinephrine, 1 ml to be diluted in 10 ml of saline, and keep the 20 ml of saline flush ready. Okay, so the person, let us say I am on the, or Dr. Atul is on that side. Dr. Atul says, okay, I'm getting epinephrine ready, diluted to 10 ml, 20 ml is ready. Great, well done. This is all mutual respect. And the chest compression continues. After 2 minutes, the record person says the 2 minutes over. Okay, can we have the rhythm? Can we see the rhythm? Okay, the rhythm, the person on the rhythm says the rhythm is still shockable, it is still VF. Okay, give second shock. So Mishra is ready, Anil is ready. He charges the thing and again looks around and looks for in the meantime, the compressor shuffles. The person on the IV line is ready with the epinephrine. So the second shock is given, shock delivered. The compression starts once again. At the same time, the person on the IV line says, should I give the epinephrine? Yes, please do, go ahead. 10 ml of 1 in 1,000, 1 in 10,000 epinephrine given, and the IV is flushed, and I have raised the arms. Great job, well done. And we are ready for the next cycle. At the end of with the third cycle, if still it is a shockable rhythm, this is the time when amiodarone 300 milligram is given in an adult. If amiodarone is not available, then lignocaine 1.5 milligram per kg is given. So this is the way the cycle goes on. So every 2 minutes, a shock is delivered. And with the second shock, we give epinephrine. With the third shock, we give amiodarone. With the fourth shock, we give epinephrine once again. With the fifth shock, we go on to amiodarone half the dose. So this is the way the algorithm goes on the shockable side. On the non-shockable side, it is very important to understand that a flat line or an asystole or a pulseless electrical activity is a very dangerous situation. So first of all, again, reiterate 5 H's and 5 T's. Is there any reversible thing which we are missing? If that reversible thing is there, please take care of that immediately. At the same time, it is not a shockable situation. So as soon as we have the IV line in place and the H's and T's have been taken care of, we'll immediately give epinephrine. on this side, the same dose, and it will be repeated every 2 cycles. So once I have given it, after 4 minutes, I'll give it once again. After 4 minutes, I may need to give it once again. At the same time, the chest compression, high quality, carries on. At any time the rhythm becomes shockable, we go on to the shockable side. At any time on both the algorithms, when the patient becomes conscious, he is responsive to return of spontaneous circulation happens, the team hands over that patient to the ICU team to manage the post cardiac arrest scenario of the patient. Does that is
Yeah,
that fine?
Dr. Rakesh, you have beautifully explained the algorithm part and the team dynamics, which is an
Yes.
essential part in saving the lives.
So I think one thing which I can, before I hand you over this, we said in the beginning that the philosophy of resuscitation involves prevention in a huge way. Dr. Atul, we have seen that if the person is shifted to the ICU before he gets into cardiac arrest, if we can identify the situation where the patient can go into arrest and they are shifted into the cardiac arrest, the chances of their survival neurologically intact increases to almost 36 to 40%. But if they get arrested in the ward, they are resuscitated there and then shifted to the ICU, the chances go down to as low as 14 to 18%. So a huge 100% change. So it is, you are the people who are visiting and standardizing all the things. I'm sure that you know about these rapid response teams which have come up in a big way in most of these hospitals. And these rapid response teams are the ones which are formed of the absolutely frontline people, the interns, the first year postgraduates, the nurses, even the attendants and technicians. They are objectively looking at the patient and identifying that the patient's condition has deteriorated, and they are given objective criteria. Okay, this patient's pulse rate is 100. If it jumps beyond 140, if it goes below 60, please alert the rapid response team so that they can stabilize the patient before, as soon as they become unstable, right? And they start acting and they prevent the person going into an arrest situation where we needed to go for the code blue. So the rapid response team is a very big plus point wherein we actually prevent arrests and a need for code blue. So I'll hand over to Dr. Shakti to.
This was the stitch in time that saves 9.
Yes, absolutely.
Yeah.
Absolutely.
And this is probably beautifully used in the COVID times, right? To demarcate in the pulse, the SpO2 goes below 94%, time to shift to the hospital. The respiratory rate goes above this value, time to shift to the hospital. Probably that decreases the strain on the hospital also, and the patient is optimized early also.
And from hospital one ward to the ICU, when do they shift to the ICU?
Yes.
And so on.
Yeah. So they have made criteria in this also. So just to summarize the whole thing, that the code blue situations are often sudden and unanticipated, and if you are not prepared for the code blue situation, chaos will follow. But we want you to be prepared for code blue situations so that the code blue team works smoothly, and the members of the code blue team may have they have been trained individually, but they in a bigger hospital they may have never met, or they must have seen that, yeah, he's working in this hospital, so they have not previously worked together. But as Dr. Rakesh has earlier said, that the language of resuscitation is same everywhere. So if you have learned the language of resuscitation, whatever situation you are in, whether you are in a hospital situation, outside the hospital situation, whether you are in India or abroad, the language of resuscitation remains same. So if you have learned the correct methods, the systematic methods of how to perform a CPR, then the language of resuscitation is same. So you will gel within the team. So team members who are working in the code blue team, they have certain key responsibilities and you have to follow those responsibilities. So a methodical approach and accurate documentation is also very essential to have the best chances of successful resuscitation. Now, the decisions, as I earlier said, that taken in first few minutes of the code will make a difference between living and dead. Now, every code blue situation is a stressful situation and it is time sensitive. So you have to think fast, you have to act according to guidelines, and you have to adequately train yourself for code blue, like on mannequins or simulations, which are an undisputed necessity. So these kind of webinars which Dr. Atul Kochhar has envisaged and brought us in, I thank Dr. Atul Kochhar for this, that he has thought of it, that we are training people uh, for code blue, and the NABH under the guidance of Dr. Atul Kochhar has recognized this, that there was some lacuna in the code blue which the assessors were going or the hospitals were facing. So it is a targeted and continuous training of the hospital staff and the code blue staff, which is ideal situation. And if we can treat these patients effectively, they will survive. So chances of survival increases, and simulation and these frequent trainings are a good. So once you are trying to improve the code blue performance, you can assure overall quality of the care. You are greatly reduces stress level of the all the staff members, because if they know what to do. If they don't know, the stress comes in. And the major part impact of code blue performance is that there is a return of spontaneous circulation. So once we do good code blue, we are gel like a team. There is a return of spontaneous circulation in many cases, and this also ensures improved data collection. We can see the kappa also. Corrective and preventive actions can be done, and the liability risk of the hospital is also reduced if we see, because many come to the Delhi Medical Council that this person has not been treated well. So all these things, the liability which the hospital faces, they will also reduce. If you have well documented, your core team is good, then the liability also reduces. Now, the role of any assessor, that means it is not the assessor which is going from NABH side. It is the simulation part also, which the hospital is also doing. He is also assessing themselves whether the code blue team which we have formed, is it the training on code blue evident or not. So those, and how quickly the resources are provided. Is there some resource short? Because sometimes when the core team comes, the defibrillator might not be working, or some other instrument is not working, maybe. So once something falls apart, the everything goes down. Now, so we have to assess, train, assess regularly, so that now the key components which are important in this situation is whether you are familiar with the code, you have delegated the clear roles and responsibilities to each team member, and you are performing the high CPR as per the guidelines, the latest guidelines, and you have accurately documented whatever is there. Now, once you have all these documented, the as you have seen through this presentation, that it is very simple. There are many situations which will come across, but there is a common approach. And once you learn this common approach, it will have de-stressing effect on the teamwork. So simulation, learning by webinars and on mannequins, it is essential part. And I thank Dr. Atul that you have invited us for this. So many situations we have discussed, Dr. Rakesh, Dr. Sunil, and Dr. Misra, and with you, Dr. Atul. So this is unique, it is very simple. If you have learned it, it is very simple. Language of resuscitation is simple. It is a common approach, and teamwork is what will save the patients. If Dr. Atul, you have any questions, or the participants?
Yes, sir. Of course.
Yeah.
I mean, firstly, you don't need to thank us, sir. It is on behalf of NABH and the entire fraternity. We are deeply, intensely grateful, actually, for this wonderful training. And we also realize that there are constraints because we have attended your live trainings, and webinars cannot be a substitute for a closed door, small group training. But still, we have had an excellent response. Just to tell you that 990 people on Zoom platform, and on the webcast till Abhi, as a real thing also 425 people are there, and on the top level 645 people. So total of about 1500 people learned from you. We have had pan India representation from every state, from Jharkhand, Vijayawada, Mysore. I can see the list, and they're all complimenting, sir. They're all complimenting. There are a whole lot of compliments. Rajasthan, and a big team from Indraprastha Apollo, because they all have mentioned, and some of very senior assessors, principal assessors have logged in. Sandhya Shankar madam, Josephine madam. So there are so many of us across. So they have attended, and there are a whole lot of questions also. Dr. VP Singh knows, he has a legal question actually. There are many comments, there are many questions. I'll just take few. One is how to proceed if relatives of patient refuse CPR. This is from Dr. VP Singh, MD, LLB. So this is a valid question actually. Can patient's relative refuse for, I mean, we already have DNAR. Can we stop sharing screen, sir? I mean, so that people can see you. I mean, there are some constraints of this Zoom and webinar, because at a given time, people have logged in through a mobile device. They may not be able to see all of them.
Okay.
Sir. So any comments on that? It can be, we don't want to have a detailed this thing. There are many technical questions about COP2Bs,
Sir,
this and that, but
the DNR is a recognized entity, which the patients can give advance in an advance. Maybe the patients who are moribund conditions, advanced cancer stage, which are difficult to get resuscitated. Patient is a 95-year-old male who has suffered many comorbid conditions, has a cancer which is flourishing, he has pain. He has given an advanced notification that he should not be resuscitated. In those cases, yes, we can.
But I think if you may allow me to intervene, I think the question is meant for a situation where you want to do it and the patient's relative don't. Do I understand it right, Dr. Atul?
No, so just written that how to proceed if relatives of a patient refuse CPR. I mean, this is
I personally feel that usually when we are asked this question in our sessions, it means that we think that there is a chance that we can salvage the patient. The patient's relative don't, and they don't want us to do anything. So that is a slightly tricky situation, if I may say, because if we feel that the patient is salvageable and there can be medical legal implications for the reasons why they don't want the patient to be resuscitated. So I feel that please correct me, Dr. Sunil, that if we feel that this is a salvageable situation, we'll have to tell the patient that this is a situation where we are very reasonable. There is a reasonable chance of saving this patient. If it is a moribund cancer patient, whatever, in that case, I'm sure it will be immediately decided that, okay, very well, good, I think we should not.
So
and advanced directive,
if you can take care of the reversible causes, we know why patient went to cardiac arrest. I think it will be criminal if you don't resuscitate.
Correct.
Whatever the relative may say.
I concur, sir. Totally.
There might be, there is another angle which just occurred to me. We have been talking about, we keep reading about and hearing about doctors being assaulted in all kinds of hospitals, government hospitals, private hospitals. Now, it brings me back to the scene safety situation. If we first try and communicate with the family and say, this is like Dr. Sunil said, that this is a reversible condition, we should attempt it. If they try to physically stop us by threats or whatever means, I think wisdom lies probably in ensuring scene safety and informing the security or whoever and documenting this. I think the question might have originated from there. What do we do to ensure our own safety as healthcare providers if such a situation arises?
I think we can leave out of this discussion because then it will complicate a lot.
True, true enough.
The patient
very important.
doesn't want.
That's very important.
I know it's very important.
So I just tried to put it in a nutshell. This could be the concern, and this is probably what we should do.
Absolutely right. Any other question?
there's another point, sir, which Dilip MK wants to know, that considering the pandemic, I mean, you've already answered that actually, Dr. Shakti, beautifully, that any advice for the public? I mean, suppose somebody is in the public and somebody collapses wearing a mask on or something, then what is the advice? But you already, I think, mentioned very clearly that giving breaths is an option. I mean,
Yeah.
if you, the lone
Lone rescuer, and you
then
can
you
only give chest compressions.
correct, sir.
And
There are
it is also recommended that the mask on the patient's face should stay there, because during chest compression also there is aerosolization.
Yes.
And therefore, if a mask, whether it is an oxygen mask or a plain mask which the patient is wearing, let it be there.
okay, sir. And there are comments like Gaurav says that adequate number of AED should be there at every area of hospital, and NABH should make it mandatory. So I mean that is to be discussed. And Mr. Jalil says that NGO government should provide AEDs at all places of mass gathering. So I think
Absolutely.
Yes.
these are very
Wonderful idea.
Wonderful idea.
and we should make efforts for that. So how many compressions for a child? So Kamaljeet wants to know that how many compressions for a child?
The compression rate for a child remains the same as an adult if there's a single rescuer. If,
Correct.
however, there are two rescuers, then from 30 compressions and 2 breaths, it goes on to 15 compressions and 2 breaths.
Okay. So, sir,
But the
I think-
duration for one cycle, I mean, one complete cycle remains about approximately 2 minutes, which means about instead of 5 such cycles, you will have about 8 or 9 such cycles before the 2 minutes are completed.
And Dr. Mahesh Kakadia wants to know that approximate price of AED, that is one. And 4 times he has mentioned that please make this thing available on the site because I missed some portions. So first part you can.
The price varies from 75,000 to 1,50,000.
Okay.
And maybe the
So these are,
50,000. But whenever someone is buying the AD, one has to ascertain that it conforms to some standards, like the US FDA or the European CE. Even the local mates are available, but since this device has to be 100% accurate in detecting the ventricular fibrillation, so we cannot compromise on that. So it has to be standard, some conform to some standards.
And it should also be conforming to the latest guidelines. Maybe
Absolutely.
some old AEDs are available which are not conforming to the latest guidelines.
correct. So I think that's very, very important for every procurement team also in any hospital to look into the latest and not go for L1 only because lives are at stake.
Yeah.
And is the pocket mask single use? I mean, there are questions about that.
It is a single use. It is single use.
Sir?
It is single use. Not costly.
Pocket mask
Yeah, not costly. 300 rupees
what is
approximately.
the price range, sir? What is the price range for the pocket mask?
300 rupees approximately.
Okay, so it is okay. Then there's a Pramod says tabletop assessment, tabletop training. I think we can, because sir, we realize that having attended your core trainings, that though this web and virtual training has been very useful, but we need more closed door trainings actually on a smaller number where you engage everybody. And if it's a live training, then you actually make people do the compressions, which entire NABH office also you were. So we are grateful that you trained. So, and again, we have to revisit and do hands-on training in smaller populations. There is no substitute. And there are lots of comments are excellent. And Dr. Rakesh sir, I think there are wonderful comments because you spend so much time on the team dynamics. And as a assessor, which Dr. Shakti said, we visit and we see that majority of these code blue teams are the best people of that hospital. You know, majority of our hospitals take great pain in choosing the right team, but some where we have gone, I personally say myself, they're doing lip service. I mean, they don't know the basics of M1, M2, M6, each role, each defined. So they should not go, I mean, through the motions, but actually be involved. And what is the role of a recorder? I mean, I think that was a very beautiful small sub-session, if I can say, on the effective communication effective
that is what
team management. Actually, that is very
Shakti told me that this is a very important part and spend more time on that So, and it is very close to our heart also, because we feel that
Wonderful, wonderful. I think, I mean, your average,
wonders.
correct, sir. Correct, sir. So I think this is, and there are actually, if I could start reading the compliments which are there on the website, I mean, there are many actually. So maybe I'll post them individually to you. Any other thing which there are still many people there, sir. So any specific precaution Purnima wants to know about women patients actually? So women patients and disrobing in public and all that. So any sensitivities involved there? How can, because you have to expose, and it is a question of life. So
I
what
think
is your take?
Anil touched
I,
upon that. He can
yeah.
elaborate.
I understand the issue being exposing the patient's chest on a roadside or in public when there are people around. There is a very simple solution. You see, the point is the whole idea of exposing the chest was to identify the right space where to give compressions, right? Which is roughly mid-sternal. So the other way of doing that is without exposing the chest is somebody can feel where the jugular notch is with one hand, feel where the Xiphi sternum is with the other finger, find the center spot, and without exposing the chest, try and do compressions there. I mean, this is a close approximation, I would say.
And I will again request that even when we are doing that, if we have a lady around, he
It's
or she
always
should open the undergarment so that they are out of the way beneath the skirt or shirt or whatever, so that sometimes there is a kind of a spring kind of a thing which will reduce the effectivity of the chest compression. So just pull it up or down. Some lady can do that under the upper garment, and or you can put a
Part two,
chunni on top of
yes,
it.
sir. Part two of the same question is that Purnima Kulkarni wants to know that can we put a like AED pad on the clothes?
No,
I mean, this is a
that is
normal
exactly
confusion.
what I
Cannot.
was saying, that you can put a chunni or a sari on top of it, but once the AED pads are needed, they have to go below that sari or below that.
On the skin,
on the skin.
directly
On the
on
skin.
It
the
is
skin,
it,
Has to
it,
directly
touch
it
the
is
Delhi.
skin
it
because
is only meant for Hindi movies where you can do it over an overcoat also.
because
Correct.
I in the special situations I told you that even the hairy chest, which is fully exposed,
Mm.
the hairs itself can cause some obstruction. So those hairs also have to be shaved.
And sir, one very important point, Dr. Mishra probably always says that he missed this. Before going into any resuscitation outside the hospital, announce, I am so and so, I am doctor. I want to help this patient.
Correct.
So actually, means you are not making scenes safe for the patient. You're telling the people, I am doctor. Making scenes safe for yourself. That's very important.
And just before the wrap up, there is one thing which I'd like to say. I guess when we give them the message that they must practice and before they use it on patients, every time they use code blue, this is something which we do all the time and we train. They should always have a debriefing session. When they
Correct.
use it in real life situation, after they have dealt with it, the team, the code blue team should review what they had done, because that should be a learning process also, not just a self-assessment, but also a learning process.
Correct, sir. I think there is so much to learn actually, but you covered also. I mean, to say that so much in including the rapid response teams, the team dynamics, the importance of each and every member of this thing, effective communication, BLS, then the basics of advanced life support. I mean, so, but once again, I think we'll keep revisiting this again and again, and all those who are keen to revisit the same link, YouTube maintains that link till evening, so that is they can keep revisiting and seeing that link again and again. That is one thing. We'll seek your proper permission to maybe edit and put it at a later date on our website also, and we'll encourage people to attend those core trainings also, because they cannot be a substitute. I mean, this webinar cannot be a substitute for a closed group training with practical hands-on experience. I mean, so that is something I think people. There is a limitation of these webinars. That is one. But really grateful, sir, for sparing your invaluable time to be and spend this prime time. Actually, we know that Dr. Shakti is still in hospital. Dr. Sunil, sir, I mean, all of you, I mean, you spared your invaluable time to be with us and be with the assessors. And on behalf of NABH, on behalf of entire audience who are there. Still, there are about 400 people logged in from this and 900 people are still on with us, sir. I mean, so really grateful, and all those who are watching. So thank you so much once again, all of you. And once again, to all the audience, the wonderful audience who are with you, you please keep visiting our website nabh.co for updates. We are enhancing our Quality Connect initiative, which will bring you a whole lot of trainings, including clinical audit, every aspect of quality, because these will be free to air trainings taken by master assessors also, master practitioners also, and masters of quality from all over India and international. So this is our NABH tribute to all you people doing good quality work there. So thank you so much once again, all of you, and we'll log off now and keep visiting our website for updates and keep registering on our site for these free trainings. Thank you so much once again.
Thank you,
Thank you.
Dr.
Thank
Thank
you.
you very much. Thank you, ladies and gentlemen.
Thank you, sir.
Thank
Thank you.
you.